Wait. Right. So good evening to everyone. Thank you for attending the webinar we've arranged. So this is under the Health Systems Thematic Circle of the People's Health Movement. And whichever time zone you're in, good evening, good morning, good afternoon. So earlier last year, we were thrown this statement by our friends from Viva Salud regarding a coalition that had spoken up regarding the worsening trends we've seen in healthcare worker migration, especially with the brain drain going on in the global south. And of course, as the People's Health Movement, and since we had members who were on ground, we wanted to expand this discussion further and see what the actual conditions are in our member countries, in our member country circles. So we called for submissions for case studies from different countries, and we wanted to see what factors had affected migration, particularly of healthcare workers, especially in the global south. Because we know right now, liberalization, with neocolonization, the free market has endangered healthcare services, especially on ground, and especially those in poorer income countries. It's usually the health of our citizens on the line. So what are the conditions that make these circumstances worsen? And we've invited a few of our members who had submitted papers to discuss more in detail, although, of course, since this is a webinar, as concisely but um, as much as they can in this time span given. And this is also a peek into a project that we're making, which is the compilation of the case studies submitted. And I forgot to introduce myself. Hello, I am Jamie Dasmariñas. I'm from the Philippine Country Circle, but I am also one of the coordinators of the Health Systems Thematic Circle. So again, thank you for joining us. And I won't keep the introduction long. So I'd like to introduce, we have 5 speakers today. I'd like to introduce the first one, who also used to be our coordinator here in the Health Systems Thematic Circle. She is currently with the WHO Regional Office for Europe as their technical officer for human resources for health. It is my pleasure to introduce or give the floor to Salakshna Nandi. Salakshna, please unmute.
You are muted, Sulakshna.
Okay. Okay. Hi, everyone. Can I confirm with Deepika that you can, and Jamie, that you can see only the slide?
Yes.
Yeah. Okay. Great. Okay. Really, really, very happy to be here with all of you. So today I'll be presenting on behalf of the WHO European region this report that we've recently done on the health workforce migration in the European region, and I will be sharing some of the data, and I'll share the link of the report in chat, so you're able to access all the data and all the information that I'll be sharing. But before starting on the report, I just wanted to highlight that, and this also has implications for the kind of data and the kind of analysis that we do, that when we're talking about the health and care workforce, it is not only about nurses and doctors. However, currently the data systems may not be capturing, the wide range of health and care workers who actually migrate, or even doctors or nurses who migrate as informal carers, long-term carers, and so I think that it's important to keep that in mind. So this is the report that we've recently launched, and I'll share the link later. I'll just go through it fast, and it's part of this commitment that WHO European region has, and this mandate has on implementing the framework for action. And as you can see, this is a framework that the regional committee approved, and it talks about retention and recruitment as a core pillar of the framework. Within that, looking at addressing out migration and looking at ethical recruitment. And for those of you who are not very familiar with the European region, it consists of 53 member states, from UK, to Russia, to Central Asia. So that's the coverage. So just to give a brief idea of the kind of data that I will be presenting. So you would have all heard about the National Health Workforce Accounts. So this is the National Health Workforce Accounts data that is collected. However, in the European region, there is like a separate system which feeds into the WHO's NHWA, and it is called the Joint Questionnaire, which is an annual survey that WHO Europe does with Eurostat and the OECD member states. I will be talking about two kinds of data. One is on stock, that is in the current situation in each country, or in countries, what is the proportion of health workers who are trained abroad, who are foreign trained, and the second would be the inflows, the annual inflows. Now, there is another data that's usually collected that's on foreign-born workers, which gives a much more clearer picture, because there might be, certain, health workers who train in another country but come back to their own country. But in this data set, they would be, for example, if there's a doctor, a student from Bulgaria who is studying in Germany and comes back to Bulgaria to work in her own country, the data will be that person will be indicated as a foreign trained worker. So there is a bit of distinction that needs to be made. But right now we are only going to talk about foreign trained, and in European region, around 20 to 30 countries report this. This report is based on data of around 20 to 30 countries, because a lot of the countries may not be collecting this data. So has the migration of health workers in European region increased? So when we see the annual inflows, when we see the stock of foreign trained doctors and nurses, we see that in the last decade, there has been a 58% increase in the stock of foreign trained doctors, and 67 increase in the proportion of nurses who are foreign trained in countries. And within this figure, Germany and UK account for 62% of the growth in foreign trained doctors, and 88% growth in foreign trained nurses. And you will see that later on also. When we look at the number of doctors and nurses entering into the European region, we find that in the last decade, there has been a 3 times increase of doctors and 5 times increase of nurses annually coming into the European region. And there is some data gap during the COVID period, but if you see the data from 2020 to 2023, I think you can see the rise. Now, like I said, the annual inflow growth was particularly high in UK for both doctors and nurses. And again, when we look at within the European region, the sub-regions, we find that all the sub-regions, there have been an increase. However, Germany and UK continue to contribute most to that increase. So what are the main doctor and nurse migration flows in Europe? 60% of all the annual inflow of doctors were trained outside the European region. And we will be hearing from our colleagues from the other regions. So, so we'll just take a look at where they're coming from. But 60% are trained outside these 53 countries that I was talking about. And when we look at the annual inflows of doctors and nurses, we find that sorry, yeah, uh, yeah, this is the country-wise sort of the highest proportionate countries. But like as you can see, this pattern is mainly due to France, 5 countries, that is UK, Germany, Spain, Ireland, France, Spain, Germany, and UK. And in the other countries, the foreign trained doctors were mainly trained in another European region. So I'll just show you the details of that. So you can see, for each country, what is the sorry. Yeah. So you can see for each country, when you look at the pink ones are the largest number of highest proportion coming from outside Europe, and the blue countries are the ones which are within Europe. So you can see for United Kingdom, for Spain, for Ireland, for France, for Germany, you have a number of countries, I think, for whom we have some case studies coming up today. And similarly with nurses, the 72% of the annual flow of nurses were trained outside the European region, with again Ireland, UK, Germany leading that proportion. And again, when you look at the countries that nurses are coming from, for instance, in UK, it is India and Philippines has the largest number of, the highest proportion. For Germany, it is Philippines. So you can just look at some. Even in the report, I will not go through much detail. And similarly, so that was out of from outside the European region. Now within the European region, again, there is a flow from Eastern Europe to and from southern Europe to the rest of Europe, as you can see in the map. And this pattern has been reinforced by the Ukrainian health workers migration, but there is a large number of migration from southern Europe to the more northern European countries. And when we look at the northern and western European countries, that sub-region, it's a circular flow, so they go to each other's countries. So for instance, the nurses of Denmark, go to Sweden or go to Norway. So you can see the kind of circles that are there. And nearly all the flows to the Eastern European sub-region were trained in other countries in the same sub-region. So this is the eastern part of our region, in which you have, for instance, doctors from Kyrgyzstan going to Kazakhstan, or health workers from Tajikistan going to Russia. So again, that's they remain in the eastern part of the region. So the reason, the conclusion is that even within the European region, that there are increasingly more complex patterns of migration, even though it's predominantly from outside the region, but even within the region, there are a lot of flows. And this report also has case studies that delves into and goes into a bit more detail about these flows and looking at different sub-regions within the European region and looking at different countries and some of the explanations for migration. And then there are some other countries which have a higher, and then now we look at the stock, and then again, we find that many countries are highly reliant on foreign trained doctors, but fewer countries are highly reliant on foreign trained nurses. In that, Iceland I'm sorry, Ireland is the highest. Um, and when we look at outflows from the European countries, we do know that health workers go to Australia, for instance, from the UK, but the data is really not available for that. And there are some other mobility patterns that we have seen in our report and the study. So there is some cross-border commuting, which is a daily commuting, for example, France to Luxembourg. And there is also a large number of international medical students that also, like I said, skew a bit of the data. For instance, I was in Bulgaria yesterday, and then so we find a lot of, so in the data it shows that a lot of Bulgarians, a lot of people from Germany, trained in Germany, are coming to Bulgaria. But then when we see, it's actually Bulgarian students who've gone to Germany to study who are coming back. So the data on the international students also needs to be considered in this. And of course, there is displacement due to conflict. So there is mobility due to the conflict in the region. And these trends would definitely be increasing, and as we have aging workforce. So the conclusion and the policy responses, which are being suggested in the report, is one, for the countries, the destination countries, to really strengthen health workforce sustainability and self-sufficiency by reducing the dependency on international recruitment and investing more and more in domestic education and planning, and also improving retention strategies so that the more young people are attracted to the profession, which is which is a crisis in the European region as we see it, and also improve the working conditions and mental health. And provides mental health support. You would be aware of the WHO Code of Practice, so enhance the uptake of the WHO Global Code of Practice in ethical recruitment. And WHO also has a guidance on bilateral agreements, and I'll share all these links in chat. But so to try and promote, so countries really need to promote that guidance and do the agreements as per the guidance. Improving data collection and monitoring is important to understand all the nuances, and it's also necessary to facilitate not only regional but interregional dialogue, because as we can see, it's really an international mobility migration issue, and one region in its own cannot really solve it. And last but not the least, enabling inclusive work and environments, promoting equal treatment, non-discrimination of migrant health personnel, and really advising countries to develop policies that would enhance, that would promote non-discrimination and inclusivity of anyone who is going to be migrating to those countries from other foreign countries. So thank you very much, and I hope I've kept to the time.
Thank you, Sulakshna, for giving us a peek into the trends happening in Europe. So for our next speaker, for our next panelist.
Rakshita.
So yes, sorry. So she is the National Professional Officer for Health Workforce of the WHO Country Office in India. She is also one of our key members in creating the interview schedules that most of us use for our data gathering. So we'd like to call on Dr. Rakshita Kanijo.
Thank you so much, Jamie. I just want to confirm if my slides are visible to everyone.
Yes, we can
But
see
not
that.
in the slideshow mode. If you can switch to
Yes.
slideshow mode.
Okay.
It's showing the notes. The next slide it is showing.
I'm not able to do that. Wait, let me
Anyway,
stop
go ahead.
sharing.
Go ahead. It's clear enough, but we get a preview of your next slide before you show it.
No, I don't want that for sure, sir. Just a minute. I'll just try and see if I can change that bit. I should have tried this
Go to
before.
display settings in the middle, that thing on
Yes.
top, middle.
Uh,
Display. There are three things written, no? Show taskbar, display settings, and end slideshow. So if you go to display settings, it should give you some
sorry,
option.
I am not able to see those options. Wait.
Okay.
We can see it on top, Rakshita, where it's projected.
The
Wait,
side
oh, this
Yeah,
I'm
yeah.
seeing
Yeah.
on the
Yeah,
other screen.
Right.
Sorry, I have two screens here. So does this help?
Oh,
Yes,
okay,
yes.
there we
Okay.
go. All right.
Okay. So I think I'll just begin with the India experience, and I would like to thank my contributors, Revati, Alakriti, Deepika, Rupa, and Adityan, for really putting together all of this, which I am able to present today. So it's all on their behalf. I would like to begin with where Sulakshana actually left. What are the regional variations? And I think Southeast Asia region is one of the youngest regions, and we are producing a lot of health workforce, which is quite evident from this slide in particular, that our shortages in the region are actually decreasing. And it's one of the fastest or the rapidest reductions that we can see. And it is essentially India is one of the main contributors to reducing these shortfalls. But given the global threats and conflicts, WHO has also overall revised the shortfall projections upward to at least 11 million. How we see the health professional migration dynamics within the country, I think we all know that a large number of medical doctors and nurses are being produced in the country, and along with the allied healthcare professionals, the MBBS seats have increased substantially, but at least 50% of the colleges are still in the private sector. The nursing as well has increased, but 80% of almost the colleges are in the private sector. So education-wise, there's a large chunk which the private sector is contributing to. And the similar cases in terms of providing services. And the state councils, the National Health Professional Registry is actually maintaining all of this. And for nurses specifically, there is a live registry system in the country, which the council has adopted. So it does give us some live updates, but data still remains a challenge. Private sector practice is still allowed in certain states when it comes to the regular or the government staff, but there are challenges in terms of recruitment, retention, and availability of positions in the government sector. There are care value chains. We do understand that there are internal migration that is happening between different rural and urban, but also cities to cities. And apart from that, I think the financial and the non-financial incentives which are there also contribute largely to the health workforce also moving outside the country. And given the regulatory and the ease of, getting positions abroad, those kind of facilitations, which we will see in the case studies ahead, are also contributors. So largely what I would like to say is that India is no longer on the WHO safeguard list, which essentially drives the ethical migration of health workforce. It positions itself as a global skill hub, and the Heal by India initiative is one of the leading, uh, uh, you know, uh, uh, one of the main drivers for the government of India. And recently, the WFME recognition that India has got for a period of 10 years also includes the new medical colleges that are coming in for the recognition of medical doctors across US, Canada, and other countries. And last week itself, India has given an approval of 41 new medical colleges in the country, and it aims to expand these seats by approximately 75,000 in the coming years. And data is with the councils, what we just discussed, but still there are updation challenges. The stock and the flows, which were shared by Sulakshana, are very difficult to track within the country. And there are high vacancies, and the government services are also becoming more contractual in nature, which is also a challenge given the workforce environment that they're working in. The push and pull factors, which we are all aware of, are also exacerbated when it comes to these conditions in the state that we are in. So a lot of health workforce is migrating. We start with a small union territory in the country, and Puducherry is a great example when we look at that. It's a very small population of 1.2 million given the country's larger population. It has a very younger age group, and which is a case even for nursing. When we look at SEER as a region, at least 50% of our nurses are below 35 years of age. So we are a very young population, and the overall literacy rate in Puducherry is quite high. And there's a large number of network of medical colleges and nursing colleges, mostly in the private sector, and also there the public health system is good. So the access to services is good. There is health workforce available in the public system as well. But here there is a complex interplay of nursing education and employment, which is happening mostly in the private sector. And there is a worsening in terms of employment terms, which are also, minimum wages, etc., are ingrained, and the working conditions are not really set up to the par, or they're not very well defined or adhered to. And the government jobs are also getting contractualized a lot more than what used to happen in the past. And thus it sort of becomes a push factor really in this particular small union territory. Even though people are facing some cultural and language barriers, there is a professional de-skilling which everyone is talking about, in terms of, you are being trained as a nurse, but you are you are a caregiver or a care aide in another country. But still, I think the monetary benefits, the fair practices that exist in terms of, career progression, or at least getting a stable job, is something that is driving the health workforce to other areas and to other countries. Next we come to is Meghalaya. This is a state which is in the northeast part. It has a population of about 4 million. The literacy rate is 74, which is quite decent. But when we look at the dependency ratio, it is 80%, which is quite high. And that means that the age group of 15 and more and 60 and above is much more in the state. So there is a high care burden on the working population in the state. And 80% of the population still resides in the rural areas. So the access to care in rural areas is still a challenge for Meghalaya. But recently they have signed an MOU with Japan, and this is a agency which actually hires people. And here they have agreed that in over the next 5 years, they will have 5,000 people being trained and placed overseas. And two of the main areas, apart from IT, etc., are healthcare and caregiving. We all know Japan has an aging population, and there are a lot of services which are required in their own settings. So they are also going to be trained in their languages, and cultural adaptations are also going to be part of their pre-departure mechanisms that the state is facilitating. So really, it's a state-led facilitation. There is an MOU, and also women are the central migrants here, because most of the women, at least in the Indian context, 80% above, 85% are women who are in the nursing care sector. And there is also a different challenge when it comes to Meghalaya, because it's a state which is looking at migration in a new aspect. It's not like other institutionalized states like Kerala, who have been used to, the health workforce migrating. So there are going to be caregiving obligations and a lot of internal cultural challenges which they will have to adapt to looking at this. What is really going to be challenging is that there are a lot of private colleges again here, but that too also limited in number. So the capacity to really train so many nurses in place when they are already facing shortages in their own existing system, and out migration is really seen as the system strengthening approach is sort of missing in this aspect, where the state's own capacity in terms of delivering care to their own people is somehow not being met, but health workers are moving abroad or moving out. Meghalaya is also a case where a lot of migration happens from Meghalaya to other states. So the northeastern states already have a lot of inflow from the Meghalaya nurses, and the recruitment and retention challenges are already quite significant in the state. So the state is already facing a bit of a challenge on its own to deliver healthcare services in its to its rural population with health facilities mostly in urban areas and the private sector. So that sort of a disparity was very, very clearly highlighted in Meghalaya study. And I think the same is being followed by Assam and other areas where it is going to be challenging. When we look at Kerala, this is a state which comes from, which everybody knows that migration happens, and migration is happening from Kerala both to and fro now. And the medical colleges, when you compare it to Puducherry and when you compare it to Meghalaya, they are much, much in higher numbers. The nursing institutes, even in the private sector, are much, much more. So the net migration rate, even though was much more before COVID, post-COVID, I think there has been a decline in the net migration rate. And now Kerala is also preparing for its for the reintegration of the reverse migration that is happening. Sometimes it is distress migration induced by a global health crisis, what we saw during COVID, and currently that is also happening in different parts of the world. And there also sometimes, there are inadequate social protection mechanisms which were at play during COVID-19, and they had to come back to take care of their own people. So all those things added to a reinflux of health workforce in the circular migration chain, which Kerala is very much attuned to. They have their regular migration surveys, which gives them insights into where the workforce is migrating, why they are coming back, and what are the reasons. But also, they are facilitating re-entry or reintegration into their existing mechanisms in the current scenario. So they have the skill recognition, they have skill transfer, and they are looking at it as a human capital gain, even though the employment rate post-COVID actually jumped up because of re-entry of the health workforce back into their country, and they had some challenge in reinstating them into the regular systems. When we look at the overall challenge within the country context, except for a few states, I think there's no central data, lack of national repository, which makes it difficult to understand who's going where and understand the chain of migration as well. So it's not usually a one-way migration. Usually people migrate from South to UAE, then they move on to OECD countries, maybe, and even to Australia and other places. So really understanding what are the migration patterns and migration trends will require some sort of a data, which would feed into making the policies more stronger and more relevant to the Indian context. What Salakshana just showed was actually a proxy of what India also tries to rely on these different studies, the academic data, but it limits the estimations and the accuracy that we are looking for into the policy making field. Real-time estimates are limited. We do not have a very strong live registries to understand the stock and flow of health workforce. And there are shifting migration patterns. I think we all are seeing different motivations, different destinations, and they're changing with the safety, security, changing laws and governance. Everything is changing And I think it's important to understand what does it mean for the country's health system. And reverse migration, except for Kerala, which has these regulation migration surveys, returning to India and really planning a reintegration will be a challenge going forward as well. So I think push and pull factors, when we look at it, everybody understands this slide very holistically. It's work-life balance, it's working conditions, it's income, better pay, sometimes fair remunerations, everything. But some things that I would want to throw at all of you for consideration is really, is it sustainability versus equity and human costs that are also involved in this migration aspect? There are global opportunities, definitely, but how do we balance it out with our local needs, rural, tribal, and even domestic caregiving roles? Empowerment versus dependency and gender as a main driver for migration, and how do we see these different aspects going together? And the central or the government, the central government leading it versus now the small MOUs which are happening at the state levels, how do we see them complementing each other, or at least keeping health workforce central to their bilateral agreements and the considerations that they have for safe migration practices. And the political economy of care versus the social cost of care deficits and reintegration is something which is becoming uh, more of a thing that we need to talk about, we need to discuss, and we need to bring on into the fore. And I think before I conclude, I would like to just reflect back that I think at some point in time, all of us have migrated, or we are also currently living in different um, countries or different states or different cities than that where we were originally born in. And migration will be or is a very normal process to happen. We really can't stop it from happening. But how do we make our system stronger and ensure that we know what will be the magnitude of impact that our system can bear if so many people move, and what would be the measures that will come into place when people migrate, would be a challenging aspect when we look at it. So, really, improving domestic conditions for people who choose to stay, the people who choose to work here, will be a priority for system strengthening. We don't want people to be pushed out of the healthcare system because we are not able to provide them the basic environment, good environment for working, or the basic, a pay package that is required to meet their daily requirements. So I think it's really a discussion on how do we see migration and how do we strengthen our systems, not at the cost of other countries. And I think the bilateral agreements, which I think Sulakshana has shared, brings out very clearly these different aspects. Once we know that which are the gaps in our system, we can really utilize these bilateral agreements to provide those technical gap filling, maybe some financial gap filling, to really bridge those challenges that we are facing within the country. But for that, I think the important part would be to have information systems to know who's migrating and who's not, and the reasons for it. These are just okay, Jimmy. Just
Sorry.
sources. No, I'm just closing. I'm done. Thank you.
There was a thank you to Dr. Akshita, and also Manoj commented in the chat regarding if we will be sending out copies of the PowerPoints. We'll save them into PDFs, then upload them into the G Drive for the working group so we can share them afterwards. So yes, thank you for the insights, Rakshita. I think the last part especially, it's especially true not just for India. The trends nowadays, we see the growing problems. And we had an example from 3 states with different trends. So we can move on to um the next presenter so we can see also um the trends in the other parts of the region. So our next speaker will be from Indonesia. So she is a researcher from the Mamuju Health Polytechnic and also a member of PHM Indonesia. She is from West Sulawesi, not Jakarta. So yes,
Yeah.
it is my pleasure to give the floor to Miss Nurbaya.
Thank you, Jamie. Let me share my slides first. Okay. Is it feasible?
Yes, we can see them.
Yes.
Okay. Am I audible?
Yes.
Thank you. Okay, first of all, let me introduce again myself. I'm Nurbaya. I'm from Mamuju Health Polytechnic. It is far from Jakarta, the city of Indonesia. I'm also a part of Indonesia. And of course, I'm very happy that I could contribute little things about the old migration of healthcare professional from Indonesia, how to safeguarding the interests of the migrant and of the country. And here is the outline of my slides. The first is about the background of the study, and the third is the problem framing and about the push and pull factors of the migration of health workers. The third is challenges faced by the migrant nurses, and the fourth is the key recommendation that provided by PHM. So, as a background that Indonesia actually faces a paradox of surplus and shortage in healthcare workforce. So the number of Indonesian healthcare workers is excessive. But unfortunately, the excess of the healthcare worker is not being met due to the uneven distribution, especially in rural and urban areas, in remote, rural, and small islands, because Indonesia have a lot of islands and difficult to reach each regions. And right now, based on the national ratio of the health workers and the 1,000 population, is about 2.56, which is low below the WHO ideal ratio for health worker. So Indonesia has a lot of community health centers that distributed at least one community health centers in each sub-district, but unfortunately, in totally, it is only about 56.4% that fulfill the human research composition standard, which is at least 9 health workers, such as doctors, dentists, nurses, midwives, nutritionists, sanitarians, laboratory staff, and pharmacists, and as well as community health workers. So we see lack of the good distribution. However, the paradox in Indonesia is that we have a shortage, other have a surplus, especially in urban areas. Instead of the surplus of domestic worker in such area, leading to internal migration to the less service area, it is tend to lead to an increased migration of health workers, especially to special of the medical personnel going abroad to the mostly to Japan, about 58%, and Saudi Arabia about 25%. So if the flow of the healthcare worker abroad continues to increase in Indonesia, it could potentially worsen the domestic healthcare systems, and of course, it will hamper the achievement of the universal health coverage in Indonesia. So that's the basic problem of Indonesia. The next slide is I will talk about the push and pull factors. In this study, actually, we found that there are at least 4 major factors that probably faced by many countries, such as low salary. Unfortunately, in Indonesia, the average nurse salary is around 300 per month, or it's about 1.52 times minimum wage in Indonesia, compared to the Indonesian nurse salary who work in Japan. It is quite higher. It's equivalent to up to 2 to 7 times higher income compared to Indonesian nurses who work in our region. So it's quite higher. And the second push factors is, of course, the surplus of the workforce, especially the nurse. So we have a a big number of the certified numbers, which is equivalent to 2.46 per 1,000 population. It's quite higher. So this is because of the rapid growth of nursing schools, mostly in public nursing schools. So at least Indonesia produce at least 100,000 new nursing graduates annually. And the third factors is no policy for absorption in underserviced area. Actually, Indonesia has launched the program named Nusantara Sehat. So Nusantara Sehat program is aimed to improving the personal number, quality and distribution, and service access to the underdeveloped and island region by designing the health worker. But unfortunately, the assignment period is only 2 years, and there's no continuity and sustainability of that program. And another thing is there's no affirmative action to give a greater preferences and incentive for those who want to work in remote areas, especially in islands who far from the city. And last that many nurses in Indonesia report that, of course, the salaries and the benefit often do not increase significantly despite the growing experiences, especially minimal incentive for rural workers. So those are the first factors that will lead the nurses especially work abroad. And talking about the full factors, I think as the same with other countries, the first is because of the aging population that increase the demand of the care workers, especially. And the second, of course, as I mentioned previously, the one of the push factors, lower salary. So therefore, the higher salary in they provide a better condition, work condition, and especially in Japan, they provide a positive work culture compared to Indonesia. And based on previous pandemic, it increased the international nurse recruitment. So those are the main three factors that pull the nurses going abroad to other countries. Here is some challenges faced by Indonesian migrant nurses. The first is declining skill because most of Indonesian work as a care worker, which is they do not apply their nursing skills, so they tend to losing their professional nursing skills.
Okay, technical difficulties, friends. Um, okay, while we're waiting for Nurbaya to come back on screen, um, I'd like to share what Manoj shared in the chat. So reverse migration of both doctors and nurses is going to be a complex issue in Sri Lanka too, with new migration laws in West for dependents. Many who will not be able to secure residency is likely to come back with no opportunities back in Sri Lanka. And we have seen similar patterns from our first two presenters. Yes. And maybe for now, we can open the floor temporarily for questions for our two previous. For our two previous presenters while we wait for Nurbaya to come back. Yes? Are there any questions for those who presented on the conditions in Europe and the conditions in India? The floor is open, guys. No? All right. Um, What? Maybe we could move forward first to the next presenter. Maybe we can go back to Nurbaya when um, it looks like she has an emergency for now. Yes. All right. Um. Yes. Before that, so our next presenter is um from my home country, which is beside Indonesia, sister country of Indonesia. So from the Philippines, it her presentation will talk mostly about nursing migration, seeing as the Philippines is the number one exporter of nurses right now. So may I call on the president of the Filipino Nurses United? Originally, it was supposed to be their Secretary General, Jocelyn Andamo, who will be presenting. Unfortunately, she's sick with the flu going around right now in our area. Therefore, I would like to introduce Mrs. Eleanor Nolasco, who is the president of the Filipino Nurses United. I will be sharing her slides. Yes.
Good evening, everybody. Good day. For
Right.
those who are in the morning time, it's almost 9 o'clock in the evening here in the Philippines.
Wait. Give me a moment. Sorry. Share screen. Yes. All right. Yes. Can you see the slides? Miss Lenny?
Yeah,
Yeah,
we can see.
Yes.
Yeah.
All right.
okay. Okay, so good day to all. The presentation is titled Updates in Cases on the Impact of Philippine Labor Export Policy on Filipino Nurses. Next slide, please. So I would like to introduce first our organization. The Filipino Nurses United is a national nurses labor association founded in 2015 that has since served to be the voice of the Filipino nurses who have been perennially neglected and dismissed despite our persistence in raising our issues and concerns, notably the very low salaries and dismal working conditions, such as severe understaffing. Slide 3, please. Nurses comprise 70% of all health professionals in the Philippines, and likely the same globally. We are often hailed by the government as modern-day heroes, yet this praise is not matched with genuine support or value in terms of policies and resources. Not surprisingly, overworked and underpaid nurses are flying out in droves, seeking better opportunities in countries that provide salaries and work benefits many times higher than what they receive in the country. The exodus of health workers, especially nurses, doesn't come as a surprise, given that the 35,000 average monthly pay in government hospitals is a pittance compared to the entry level of $3,800 or equivalent to 209,000 pesos in the United States, more than 100,000 pesos in the United Kingdom, and 163,000 in Canada. And it's even smaller for nurses in the private sector who are paid the minimum of 695 pesos daily or roughly equivalent to $12 for an 8-hour work or duty. Next slide, please. Even the President Bongbong Marcos acknowledged the important role nurses play, especially during the pandemic. Yet, except for platitudes calling us modern-day heroes and a vague promise at the start of his term that better days are ahead, Up till now, no substantial increase has been given. The Philippine government has appeared more eager to encourage Filipino nurses to work abroad, benefiting from the dollar remittances they send home. Next slide, please. The state of Philippine health sciences education, especially nursing, remains highly hospital-based, Western-oriented, commercialized, and largely privatized. It is profit-driven and weak in inculcating social responsibility and nationalism. This makes it poorly aligned with the national health needs and more geared towards global markets demands, ironically pushing more nurses abroad in search of better work opportunities. There is reportedly a surge in nursing enrollment that indicates an increased aspiration to work in greener pastures, especially in the face of worldwide aging population and a more volatile health situation globally. For decades, the Philippines has been among the top exporters of nurses and still is. Migration has become a pathway for economic upliftment. According to the Private Hospitals Association of the Philippines, the resignation rate among nurses hit 40% in 2022, as many left en masse for overseas work. This trend has not changed. There continues to be a fast turnover of nurses, especially among the young ones, who, after gaining some experience, are already flying out. Next slide, please. The Filipino nurse migrant in the US. The United States is still a top destination for Filipino nurses. One factor is our closer affiliation with American culture, with its big population of Filipino nurses. And of course, salary remains the biggest consideration. The estimated annual salary is approximately 3.3 million annually, or an hourly rate of 38 US dollars, which is 10 to 12 times the average Philippine nurse salary. And what are the requirements for employment? To work there, a nurse must pass the NCLEX and a language proficiency test and secure a job offer through a licensed recruitment agency. Slide 8, please. A serious labor problem involves a coercive scheme called TRAP, or Training Repayment Agreement Provision, also known as Stay or Pay, that has targeted Filipino nurses. Those who resign early from contracts face lawsuits and hefty penalties. In 2023 in Ohio, 5 nurses faced such lawsuits after quitting due to unbearable workloads, including being assigned to 30 patients per shift, leading to burnout and health risks. 2 nurses filed the case, citing extreme understaffing. Jane sued for 100,000. She was sued for 100,000, and she felt like a criminal just for resigning a week after her last day. Last we heard, the case is still ongoing. Slide 19. Recently, large-scale protests erupted across U.S. states like Los Angeles, where nurses joined rallies to defend migrant rights and patient welfare. Public health services are increasingly threatened by privatization and anti-union policies. There have also been reported arrests and deportations of undocumented migrants, leading to fear among patients and sometimes even death due to avoidance of health care. Next slide, please. In New Zealand, Filipino nurses like Tiffany and Michelle Maningo, both with 4 years of experience in the Philippines, migrated to New Zealand on student visas and spent approximately 350,000 pesos or 10,000 New Zealand dollars for the competency assessment program. Despite this, they faced 6 months of job rejections and mounting debts from loans in their hometown in Cebu, Philippines. Slide 11, please. These internationally qualified nurses are lured by promises of employment that are often not guaranteed. Even after completing competence assessment programs, many still cannot secure nursing jobs. In 2023, CAP was replaced by the objective structured clinical examination, a 2-day orientation, and a 3-hour exam process. However, it failed to resolve employment bottlenecks. While 90% of hospital wards remain understaffed, a surplus of unemployed IQNs exists. After their 3 to 6 month visitor visas expire, many are forced to return home jobless and heavily indebted. According to the International Council of Nurses, 36% of New Zealand's nurses in 2023 were foreign trained. The Philippine Embassy later issued a cautious advisory to nurses planning to go to New Zealand, while the New Zealand government emphasized if you don't have employment, you must not be in New Zealand. Slide 12, please. Other destinations. Finland offers a practical nursing program pathway to become a licensed nurse in Europe, while Germany has hosted 6,000 Filipino nurses with a bilateral agreement under the Triple Win Project, enhanced in 2022 to guarantee fair treatment. The average starting salary is 1.5 million annually. And in the United Kingdom, some 40,000 Filipino nurses are employed under the National Health Service. The Department of Health website lists other countries with bilateral agreements for nurse deployment, reflecting the global demand for Filipino nurses amid domestic neglect. Next slide, please. From the 3 countries alone, the huge remittances may be considered the overarching reason why the government has made a big business out of our important human resource as an export item. Next slide, please. Global solidarity and local advocacy. Globally, we are forming alliances for solidarity while vigorously undertaking local advocacies. FNU is committed to strengthening ties with Filipino migrant communities and building chapters abroad. As a member of the Global Nurses United, an international federation of nursing unions from 38 countries, FNU pushes for stronger nurses organizations and health workers unions, patients and communities greater access to free quality healthcare, strengthening of public healthcare system, and a stop to health privatization. Next slide, please. The key issues that challenge and confront us are globalization that manifests in reduced health budget, cheap labor, and practice of contractualization, devolution, and privatization of health services. And for the last slide, please. The call to action. Nurses must fight back. Alongside the global working class, we must demand decent work opportunities in our own country. The government must put people over profits and end the cycle of forced migration. The future of our nurses and our nation's health depend on it. Maraming salamat. Tuloy ang love. Thank you, Jane.
Yes. Thank you, Miss Lenny, for sharing until even the plight of nurses here in the Philippines. So organizing among workers, including health workers, has been key also in lobbying for, of course, your data gathering and how we forward policies or how we lobby for um, policies with fairer wages. And I believe also one of the key propositions by the FNU is not just the increasing of wages of the nurses, but also to improve actual working conditions. So yes. All right. For now, we will move on with Nurbaya. Can you? Are you good to continue?
Yes,
Can you?
thank you, Jamie.
All right. We will
And
go
I'm
back to
sorry,
Nurbaya first.
everyone, that yes, thank you. I'm sorry, everyone, that I lost my voice, and I'll try to continue my slides. If I lost my voice again, I hope that Sundar helped me to finish my presentation. Well, can you see my slides?
Yes, we
Yes,
can.
we can see them. Go on.
Okay, thank you. Again, I'm sorry, I will continue my slide. This is the challenges that faced by our Indonesian migrant nurses. The first is declining the skills, because one of most of the nurses of Indonesian work in Japan is work as a care worker, which is they don't use their clinical skills. They don't use their skills such as suction, administering injection, or managing infusion. Therefore, they tend to lose their professional nursing skills. And the other challenges faces by Indonesian nurses who work especially in Japan, they reported that they face difficulties in communicating and understand the Japanese language, especially those who work in remote Japan, because in Japan there's some specific dialect, especially in rural areas, and it makes them difficult to adapting the Japanese norms. And the last challenges is they feel isolate and mental health risk. For example, as I said previously, that care worker nurses who work as a care worker who work in rural areas, they feel lonely. The relatively rural areas make them difficult to reach the religious facilities, and this will make them feel lonely and isolated, and potentially leading to mental health problem of the nurses. Also, here is the impact of the Indonesia of the migrating health worker. So the first is there's a potential for brain drain. And the second is the reduction of nursing skill they have, especially those who work as a care worker. As I mentioned before, that the higher number of nurses who work in Japan work as a care worker who do not apply the nursing skill. And the third is carry stagnation for nurses who return to Indonesia, because nurse who work as a care worker, mostly they didn't the government and the nurse professional organization do not acknowledge their previous job as a care worker, because the government and the professional organization only acknowledge the nurse who work as a nurse who use the nursing skills. So that's the impact of the Indonesian, and of course the nurses itself when come back to Indonesia. Here is some recommendation from PHM Indonesia. The first is we need to strengthen the health human resource planning by aligning the health education curriculum with the needs of the healthcare workers, especially the needs for workers who will work in rural and remote areas. The second is by improving salary structure and career development plans for all healthcare workers in all Indonesia. And the third is evaluating and strengthening the incentive for health worker placed in rural and islands areas. So this will motivate them to work in that area. And the fourth is insist that bilateral agreement should compensate for the economic investment Indonesian government is in making training in this health workforce. And the next recommendation is we need to insist the bilateral agreement include mental health support, especially those who work in remote areas and tend to risk of mental health. So they need to this bilateral agreement should ensure that their safety and security, and of course the fair social security package for all the migrant nurses. And the last recommendation is we need to insist that bilateral agreement include the reintegration program for migrant nurses, such as providing refreshing training for nursing skills, especially who work as a caregiver before returning to Indonesia. So we need to actively facilitate this reverse migration is required. This is my last slide for you.
Yeah, you just managed. Last slide over. Yeah.
All
Yes,
right.
thank you.
Thank you, Nurbaya.
Thank
right.
you.
All right. I see. So, thank you to our third/fourth speaker, Nurbaya. So, we will move on with our last speaker for today. So he is the coordinator for PHM Kenya and also the program manager for the Society for Development and Care Through Community Action, an NGO also based in Kenya. I would like to present Mr. Dan Owala. Dan?
Can you hear me?
Yes.
Yes.
All
We'd
right.
We'd like to see you also, if you can turn on.
Floor is
Okay.
yours.
Yeah. Can you see me now?
Yes.
All right. Thank you very much for the first speakers. I will run through a summary of case studies that came from Kenya and Nigeria, because most of the issues that were raised on these two case studies were having similarities. But first, I would like to put a perspective of Kenya is in the sense that we have 48 governments, one national government and 47 governments. And here we have a 6-tier healthcare service delivery, beginning from level 1, which is at community level, to the 6th tier, which is the referral level, the referral level. And in these 6 tiers, chances of a patient meeting a doctor are only at level 4. So level 3, 2, 1 going down, most are clinical officers and nurses running those facilities. Now, with that background, having put forth our case studies, which I'm sure will be shared, having a critical examination of the mass exodus of healthcare professionals from Kenya and Nigeria, it explores systemic failures and that drives these migration patterns. And it also devastating the impact on the health systems across, countries in East Africa and also West Africa. When we look at the numbers that came from the cases studies which were provided, 13,000 K plus Nigerian doctors applied for certificates of good standing to allow them to migrate from Nigeria to other countries, to destination countries between the year 2019 2024. If you look at Kenya, Kenyan nurses, between the same period of 2021 to 2023 alone, the UK National Health System recruited over 2,000 nurses from Kenya. Nigeria, for the numbers of nurses, were almost 42,000. In countries where doctor to patient ratio is about 1 to 100 patients in Kenyan public hospitals. So these figures, to me, they don't just represent statistics, but a systemic erosion of healthcare capacity in the two African countries, these two most populous African countries. So what are the push factors? Why do they leave? Number one, of course, which is very obvious, is the inadequate compensation. If you compare what Kenyan nurses earn here to what they earn to their destination countries, is about $380 on a monthly, compared to about between 2,500 to 4,400 in the UK. And the case studies also brought out that Nigerian salaries are among the lowest in sub-Saharan Africa relative to the cost of living. The other reason is the poor working condition. We claim they work in facilities that are under-equipped, frequent shortages of basic supplies, and extreme workloads and unsafe environments drive these professionals away. For Kenya, I would also like to add there that in a country where we have so many governments, we have each government entering into collective bargain by health workers and different terms of payment with different county governments, and national government giving also their own salary payment. So Kenya has experienced a lot of industrial actions by health workers, given that mostly the county governments do not honor, even the national government, do not honor some of these collective bargain. We're just coming from one industrial action that has seen one county government with doctors striking over 5 months. And this then depicts why most doctors who have been trained by subsidized cost by government leave Kenya to go work elsewhere. The other reason is they do say there's limited career growth, restricted postgraduate training opportunities, and professional stagnation force. So ambitious workers seek to leave to go abroad for specialized studies. And the other one factor that came mostly from the case studies in Nigeria is insecurity, workplace discrimination, and governance failures erode morale of workers and create urgency to leave. So where do they go to? Which are the primary destinations they head? Top destination from these two case studies, United Kingdom was the most popular due to, English language, historical ties, and an active recruitment of health workforce in the UK. Germany has also emerged as a new destination, especially for Kenya, having entered into bilateral labor migration agreement with Germany, not just for health workers, but for more professionals, which include health workers as well. The United States and Canada have been active because of high salaries and good settlement opportunities. and structured career advancement. And now the Gulf states have also drawn quite a number of nurses and allied professionals with tax-free salaries and short-term contracts, and made it easier to travel over there. So what then are the devastating consequences for this kind of movements? Number one is a critical workforce shortage. So staffing in public hospitals is becoming or shrinking because most people prefer to live. And as a consequence, rural facilities lose 24-hour service to the people, or even weekends. You will not find a health professional working over weekends. And this is really overstretching workload in those facilities, therefore denying patients the right to health as it should be. Another thing is burnout and medical errors that come because of the slim workforce that is available for public facilities, and lost training investment, meaning each immigrating professional represent a sunk public investment. So both nations effectively subsidize wealthier countries like the UK. And here we use taxpayers' money to subsidize training for health workers, only for them to subsidize for wealthier countries when they migrate. And lastly, the deepened inequality. So rural and underserved communities suffer most. Healthcare access gaps widen dramatically in conflict affected areas in Nigeria and other remote areas. So the point here is the economic aspect of this is there's remittance provided by household benefits, which in last year Kenya received about $4 billion in remittance in 2022, but that doesn't compensate for the systemic health deficits that we have. In terms of training infrastructure, we do have both public and private training for health professionals, but the fee for private training is much higher in both Kenya and Uganda, and Nigeria. And this makes it difficult for people who want to have opportunities in getting training in private facilities becomes difficult. So, and the curriculum for training both in public and private is increasingly aligned with the international standards, and this then creates a de facto preparation for migration rather than domestic retention. So, which are the pathways and challenges for this? Is that neither Kenya or Nigeria has mutual recognition of these agreements. Neither Kenya or Nigeria has comprehensive MRAs with major destination countries. And recognitions are basically assessed by foreign regulators, and not from the departing countries. The cost range, the financial burden of this, the cost range from Uh, for a case like Nigeria, similar amounts in Kenya for exams and verification and visa processing are entirely on self-funded, not the inviting country. And another challenge is the weak agency regulation. So private recruitment agency operate with limited supervision over there, leading to exploitation of healthcare workers and unethical practices over there. Another thing is the fragmented coordination, meaning there are multiple ministries involved. The health ministry is involved, the labor ministry involved, the education ministry is involved, the foreign affairs is involved. So there's no central body that manages migration policy data. And then the emerging now formal pathways like Germany agreement represent a shift towards government to government framework with qualification and recognition and language support. So the departure of even one or two experienced nurses from a rural clinic can cripple its ability to provide 24-hour service. And that is evidence we've seen here in the country. So according to Kenya's report, there is no comprehensive up-to-date on health workers migration. I think the data gap it's also existing in Nigeria, and this is one of the areas that we will say it will be strengthened so that we get to know how many have gone to which country, how many left, how many were on subsidized education here before they left. So neither country maintains a comprehensive national migration tracking system. And without accurate data, policy planning becomes guesswork, a major obstacle for effective intervention. So I don't know if I should move ahead to recommendation or I stop there and provide our recommendations at a later stage. But one of the recommendations we had was to establish a migration observatory, improve working conditions locally here, and strengthen regulations for recruiters of recruitment agency, and implement the retention incentive. So I would like to stop there, but without urgent action, Kenya and Nigeria will continue subsidizing wealthy nations and like most African countries, and health system while our own population suffer. This is a crisis of policy failure, social neglect, and global injustice, and demand immediate coordinated response, as was quoted by a colleague who presented the Nigerian study. Over to you. That is a summary of both our presentation, Kenya and Nigeria. Thank you very much.
Thank you, Dan. So yes. We have seen then through the patterns of migration, the neglect, especially for the lower income countries, especially in terms of health services being delivered. Time check, it is 9:28 here in the Philippines. So that's, sorry, what is that in UTC?
for maybe we can have sorry, maybe we can allot 10 or 15 minutes for questions from our audience. There's also already one question asked, which I think is an interesting question. At what point does health workforce migration become exploitation rather than opportunity, and who decides? Would any of our panelists like to answer that question? Anyone? Floor is open. You can just open your microphone. Yes.
Sulakshana, I think you should try that.
Yes.
Yes, I think it's a very important question, and I think so. Firstly, I think it relates to the conditions that leads a person to migrating. So and it's important to look at it in terms of the responsibilities of governments in ensuring, a sustainable and a strengthened health workforce for their own country. So investment in training, etc. So I would put this more in terms of, what WHO sort of guidance on the global, the ethical recruitment says, or on the bilateral agreements say. So looking at governments, or supporting governments to improve the investment in the domestic training retention, in recruitment, ethical recruitment practices. Um, so I think at an individual level, it's difficult to look at it, but I think it needs to be looked at it in terms of what governments are doing to ensure that the workforce in their own countries are supported, and also that if there is any migration, that's also ethically done. So I would
So
say.
I'd like to chip in on this with one
Yes,
observation.
go.
I think that the Nigerian case study put that last line very brilliantly, that every departure is an achievement of a personal dream and a public loss. There is one question for the individual, whether it is a loss or exploitation. Many migrations are not exploitative. They are actually the recognition or a realization of a dream and an aspiration, including better professional work, including better health service, including better remuneration. So at an individual level, it is there. But there are others which are frankly exploitative, where they are provided work with their skills. One of the defining things is transparency. When people go and do not get the deal that they have been promised, that's a no, that's a bottom line. That's fraud. That's exploitation. But even sometimes when you are forced to choose and you do not have the minimum terms of labor as comparable to your peers within the situation, then there is a loss, especially when you go to a social democratic country and you don't have social security. That is because the terms of what is exploitative practice are determined there. So in individuals too, there is a question between a loss and a gain. There is. When it is exploitative, and I think the guiding principles are transparency and the question of benchmarking with the norms of the place. But the public loss is a very different thing. And again, there are situations because the huge remittances is some sort of a public gain, but they are made at the cost of a certain population. It builds a certain responsibility so that collectively, for the remittances that they provide the nation, what is the nation doing for them? There's that sort of a fairness question that becomes articulated. And secondly, that remittances offsets the lack of healthcare that it leads to in your area. So I think Rakshita in her last slide had shown that there's a spectrum of 6 questions where even in gender and empowerment, each one of these questions, the same questions can be extended across the. But I think this is the complexity of it, and within this framework, we must make our declaration. Yes.
All right. Manoj was raising his hand. Yes.
Yeah, just two things. First, what I want is to see for the question of where the exploitation starts. We are looking from what was told by Sundar is basically looking at individual level exploitation. But what I'm looking at it from a different angle, the systems, health systems of the South, or particularly the countries where they are training those. The education systems, they are training healthcare workers and they get incentives from other countries to migrate. So uh, if you look at what I see in Sri Lanka at the moment, now it is bit reduced, but within the last few months, but we have seen people have been trained, nurses and doctors basically, and even physiotherapists and to some extent medical laboratory technicians, they have been trained from free education in this country, and we are investing huge amount and we continue to invest, and the incentives coming from the west and other countries will get them. And in our country what we see is more or less one way traffic. It's not coming, the majority of them will not come back, or they won't send any money back apart from few chocolates for their parents and their relatives. So in that case, we are investing on healthcare workers with a large amount of money, and we are maintaining systems in other countries where our systems are draining because of the colossal amount of money we have spent. So if you look at from that angle, I am not really sure where the exploitation starts from normal, because it's exploitation not at the individual level, but whole countries being exploited who are training the staff. Thank you.
Yeah, that's the notion of the public loss. There's a strong sense that even when it works at the individual, it's a public loss, and
Yes.
what's the balance there? Yeah, I think that is.
All right. Does anyone else want to throw in their 2 pence? Or does anyone else have further questions for any of our panelists? Or in general to the members of the forum? None.
Yeah, I would like to share something.
Yes.
I
Go
was
ahead.
raising my hand, yeah.
Ah.
When Nurbaya was sharing her experience, and same with Dan, I realized that we have close similarities in the Philippines. Many of our health workers are pushed by personal needs because they are not getting enough help from the government. Their income is insufficient to meet the basic necessities of their families. Hence, it's a very though it's a difficult decision for them to make, they are really pushed to go out of the country and seek better work opportunities abroad. So that was what Nurbaya, I think, was saying also. And same with Dan. The conditions of health workers in their respective countries are not positive at all. So, but just the same, in our case, for instance, precisely why we are advocating for higher wages and better work conditions, because we believe that when you give the health workers the option to choose, they would rather serve in their own countries, no? Even if comparatively the income is not as much, but they at least, especially for Asians, they are very family oriented and they would like to stay with their family. So that's one advocacy probably that we can all adopt, especially in the case of Indonesia and Dan, which I think they are doing, no, make conditions at home more viable or more positive, so health workers can opt to stay in their home countries.
Yes. Also to add, I think we should also not forget the efforts also of those already based in the countries they migrated to. For example, overseas Filipino workers. A lot of our contacts, also FNU's contacts, continue to update also regarding the conditions of health workers abroad. And this data is vital in how we lobby for better reforms for our health workers in our home countries. Also, for those who would choose to migrate abroad, because some of the case studies that were presented earlier had showed us how those who go seek greener pastures could be exploited as well. And it's a loss because one, you have someone in the workforce who could have stayed and helped with the workforce, but of course, because they have very, very bad conditions at home, that's why they left. And at the same time, for the individual, the loss of a good opportunity to improve their lives and their families' lives. So yes, Rakshita, yes.
Thanks, Jamie. I think just to add on to your point, the Kerala migration surveys that are done actually build on all of these aspects, why people are migrating, why they are coming back. So all these decision-making points become very important when it is not a choice, it's a forced migration. So you know what to improve your systems on. It acts like a feedback loop for the governments to really pick on those aspects which they need to improve. So maybe that is something that, as part of what you mentioned, improving our own knowledge, our own systems would be very, very crucial.
Yes, Lakshna.
Yeah, I just want to briefly add also to what Eleanor has said. I mean, we have in one of the case studies, the case study of Romania, where we actually find that, the number of migrating doctors have significantly reduced. So you can find it in the report. So in 2012, it was 1532, and in 2021, it came down to 461. And there was a series of interventions that were done, including increasing the number of doctors and density of doctors, improving salaries, increasing number of jobs in the public sector, etc., and other financial, non-financial incentives. And of course, the context is very different, and Romania is a much smaller country. But I think it shows that, I mean, countries can try and do things and, succeed in really creating conditions where people would want to remain in the country and have a very successful professional life. Yeah. Thanks.
Yes. Before we move on, I'd like to read some of the comments from the chat. So Elroy says, "Thank you, great presentations. The take-home lesson for me has been that the impact of global health inequity has been on individual countries, in particular in the global south. Whether you have a quote-unquote surplus of trained health workers, some countries suffer disproportionately, calling for global enforceable rules and working conditions. Indeed, the private sector gains at the cost of public access to healthcare. And of course, it is immoral. So, as Sundar had pointed out, Bridget had commented also, agreeing to a point by Manoj earlier in the chat. Wait, where is it? Um, the loss in terms of training investment is huge. There have been unresolved debates within PHM as to whether we should push for compensation for training of health workers. And Deepika, might be better if you could open your mic to share your point regarding the Nigerian case study, so that
Oh,
everyone can
no, I
hear.
was just adding to Eleanor and Sulakshna's point that many of these health workers would want to come back. And I shared an example from our Nigerian case study, where one of the physiotherapists said that migration is not betrayal, it's survival. But I hope one day we can return to a system that values our expertise. Yeah.
True.
That
It's right
Nigerian
home.
that Nigerian case study is brilliant in its quotability. I think
Yeah.
some of the best lines I've seen on migration is part of that case study. It's just brilliant.
Yes.
Ekpe is there. We would like to see you if you are there still.
Are they still here? Or have they logged off?
No, Nigeria was there.
Yes. All right. Last call for any questions, comments, violent reaction, suggestion before we close.
Does
Two more.
Deepika want to make a summary, some last words on this, Deepika?
Yes.
Yeah, I will take only 2 minutes because everything has been said here. Uh, based on all these 10 case studies, we came up with some recommendations and we've tried to summarize them, and these are very
Hello?
draft. Can you hear me?
Yeah, we can.
Yeah.
Jamie has
So
frozen.
Is it-
Yeah, I think. Jamie, you froze.
Okay,
I
there.
think she's just
Me?
going ahead with some recommendations. So
Okay, go. Yes.
yeah, so
Please do.
most of it has been said, and these are very draft recommendation. We are inviting inputs for them, and we will also take inputs from the webinar that we had today. The two main points are, one is the demand for health system strengthening in the global south and north both, and which is not something new, which is something we've anyways been demanding. We also, and especially in terms of the pillar which deals with the human resources for health, and it has to go with strengthening along with the other parts of health system like improvement in budgets, governance, etc. One slight point we noticed in our case studies, some of these countries have surplus of health workers, Indonesia, Philippines, Kerala in India, etc. So there, the strategies will have to be different as opposed to the Pacific Island states and Nigeria and other African countries, where actually the international migration is hurting the health system. So I am quoting this from one of the WHA discussions where one of the participants said that Jamaica, Samoa, and Barbados all spoke about struggling to retain staff despite improving, pay and working conditions and training, owing to aggressive recruitment of their health workers. And so it's important to do some kind of health labor market analysis to understand where the country stands, because all of these countries from global south have a shortage of workers, especially in rural and remote areas, maldistribution, and a lot of migration, not to international, but to private or to the urban areas. So that's one. And secondly, the demand for health system strengthening in the global north and destination countries, as many of our speakers said, supporting, and also which the global code also demands, supporting source country health system strengthening through financial and technical means. Many of our case studies also demanded compensation for the training that the global north countries do not have to do on their health workers. They instead import it from the global south countries. That is the other point. And the last point is, while this is happening, while these long-term measures are happening of improvement in health system, of absorption of unemployed nurses or expansion of health force, we improving the experience of migrating health workers, which is likely to continue and happen. Improved data collection is the first step, and which again is one of the key issue in terms of no data being available in terms of the migrating health workers. Bilateral agreements and formal partnerships are better than informal ones because they secure these channels, and transparency in these agreements, as shared earlier, is very important so that the health workers know what is the contract they are signing. One of the suggestion was that the exchange of health workforce should not be part of trade deals, but specific bilateral partnerships. And the last point was to address de-skilling, as we saw it was happening in Indonesia, and a Nigerian case study also mentioned it, and other issues of discrimination, cultural barriers and mental health. We will invite more inputs from this group and all the speakers, and we'll request you to uh, give suggestions. Yeah.
Right.
Thank you.
Thank you, Deepika. Yes. Wait. Before I give the floor to Sundar, I'd just like to update everyone regarding
Froze. Our internet is also getting tired.
First. Where is that? All right.
Yeah.
I'm sorry. I hope my internet doesn't lag.
Yeah.
'Cause it was lagging earlier.
It is
All right.
lagging now.
Slideshow.
You can maybe mute
So
your video.
currently we have
Double click.
five submissions from our case studies. Hello.
Yeah.
Hello. Yes, it's
Yes, we can hear
lagging.
you.
Oh no. Switching off video. Hello. Is it still lagging? Your internet connection is unstable. Anyway. Hello. Can everyone see?
Yeah,
Is it
we
still
can hear
lagging?
you. We can hear you. But your video is
Okay.
frozen.
Hello.
Jamie, are you still
Oh,
there?
yes.
Can
Yes,
you?
sorry.
I
I
suggest
want
you present
I
without the
want
slides.
yeah. I'll just update everyone without the slides. So far we have 5 case studies submitted from India, 3 of which are case studies from Puducherry, Meghalaya, and Kerala, and 2 input reports. 2 studies from the Philippines. One was discussed earlier, which was regarding nurses. We also have one regarding migrant doctors. As discussed earlier, the case studies also from Nigeria and Kenya. We have one from Indonesia, courtesy of Nurbaya. We also have a study from Papua New Guinea. Helen had submitted one, and of course, the study from Europe, which is the WHO regional report, which is actually 9 case studies in one. Um, Sundar, are we still open to any other submissions in case anyone would like to?
Yeah, we
Yes.
just, it will be a repository that will be available in the PHM website. So if
Yes.
people are worked on that, I know Wilson had told from Africa that there were 4 other countries working on their thing. So if there are more countries, we could welcome that.
Yes.
Yeah, sure.
So far, that's our progress. So with I think we've already discussed well, especially during um, the open forum, especially the commonalities between our countries. And of course, if you can reach out to us if you would want to add more for the recommendations. So far, the calls, I think, based on our discussions earlier, of course, number one is to solve root causes of poverty. Poverty and, well, the poor working conditions also, especially of healthcare workers. It's one of the main factors that push for the outmigration from our home countries. So that includes increasing wages and, of course, fixing our support systems locally, and also to restore dignity to care work. Just because you migrated also doesn't reassure that you will be treated with dignity. But one of the main problems why people do migrate is because the working conditions for health workers in their home country are dehumanizing. And that's why we're looking for, quote unquote, greener pastures. Of course, we also would like to enforce ethical recruitment. I think Salakshna did drop a link regarding international policies related to that. Also, Rakshita has, um, we uploaded a repository of resources she'd provided earlier. We can link the health worker migration working groups Google Drive if you're interested in going through them. And of course, in light of international solidarity, and of course, we all have to work together to uh, to push for improvements for all healthcare workers. So inter-country and inter-regional cooperation is key. So it's not just in bilateral agreements, but even in how we organize on the ground, how we reach out to health workers, be they already abroad or those who are still here close to us at home. So I will end with on that note first, but I would like to share, unfortunately, it my
Close again. Yeah,
of value, justice, and hope. So again, a very quotable study, and I will give the floor to Sundar for our closing remarks.
no closing remarks. It's late. I think just one line. I think we will continue this process. The process was very interesting. We have had an engagement with many countries and with the field work. So we hope that we will bring this out as an online publication, not a major publisher, just for something that we put up with the reference material on the PHM site. So we'll work on it. We aren't setting ourselves a tight deadline, but we will hope to get that out by the end of the year. Okay. So if there are people who are going to submit a thing, and we will edit it. But the other thing is that we will draw off the our what we want to see in the global code, the modifications of the global code. So our asks or our demands for the nature of modifications that we should that we would actually try to see in the overall summary. So there's an overall, the final publication will have an overall framing of the issue. Then it would have the case studies. Then there'll be a set of demands or asks or policy briefs for what countries should do. And then there will be a section on what the global code we want of the global code. So we can commit ourselves, and all the people who have contributed to this, let us stay linked till we get this thing out by the end of this year. And maybe this group on the human resources for health can continue to interact. Sometime we will meet. With all so many WHO people around, we may be able to organize a workshop that you can. We know that WHO itself doesn't have much of the funds for it, but we should be able to organize some workshop where we can discuss what we want in the global code with the WHO also. Yeah. Thank you, and thanks for this excellent participation and the great case studies.
All right. Thank you again, all, for joining us tonight. And I hope to see you all soon in the next forums. All right.
November
Bye-bye.
25th is our next, most likely, webinar on privatization.
Privatization. Yes. Just stay tuned, guys. All right. Thank you
Bye.
all.